Hey, Dr. Bellini, it's Brett. This is going to be my video simulation of a newborn assessment. For this particular assessment, we were given a history, so I will go ahead and review the history. This is baby girl Smith. She is a 12-hour-old, 32-week preterm infant delivered by C-section for worsening maternal preeclampsia. Her APGAR scores were 6 and 7. Her birth weight, length, and head circumference were all within normal limits. We are not actually given measurements for this, but we are just told that she is appropriate for gestational age. She did require brief CPAP following admission to the NICU, but has since weaned on room air and has been resting comfortably on the radiant warmer. She is NPO and is receiving IV fluid of D10W at 80 mLs per kilo per day. She remains somewhat hypotonic and is still having intermittent episodes of apnea, which is presumably related to the magnesium sulfate exposure and prematurity. So, that being said, that was actually the first step to conducting a physical assessment, which is reviewing the history. So, when reviewing the history, we want to be sure to look over the OB history, the maternal and paternal medical history, family history, social history. All of that plays into the care of the infant and gives a good overall view of how this infant may present at birth and any complications that may arise. We are given some information on this baby. We were told that she was a C-section. However, we're not told whether it was a C-section with labor, what anesthetic was used. I'm assuming she was not having labor since she was, it doesn't say emergently induced, but it did say C-section was performed for worsening preeclampsia. So one can assume, but again, you should never do that. So it's good to have all that information just to be 100% accurate. After going over the maternal history, any medications, again, like I said, we know that this infant was exposed to magnesium sulfate, so that is definitely going to kind of guide us on our physical exam. I want to make sure I gather all my equipment before going to the bedside. One thing in particular is the stethoscope. You also want to make sure to have a tape measure, a thermometer, and it's also good to have an ophthalmoscope. I do not actually have an ophthalmoscope, so for that part of the exam, I will just talk about that. Another tool that's sometimes used in neonatal assessment is an otoscope. It's not typically used in neonatal assessment due to the fact that a lot of the times infants' ears can be covered in vernix or they're small. It just doesn't provide a lot of valuable data in the neonatal period. However, once they are discharged in a pediatrician's care, that will obviously change, but for this assessment, no otoscope will be used. At this point, I have all my stuff. I have gathered the history. Now it's time to actually go and assess the infant. So once I get there, if there are any parents at the bedside, I would want to introduce myself, let them know that I'm the NNP student for the day, that I'm going to be working with the neonatal team, and I just want to perform a physical assessment on their infant and ask any questions and answer any questions they may have. I think this is always a good opportunity to kind of break the ice and get to know them a little bit and really start to earn that trust. I like to do that by, asking, does the infant have a name? Is this the first baby? Stuff like that, just to kind of show that you are there to do more than just a task, that you're actually there to listen and that you care. So that being said, I've introduced myself to the parents. I told them what we're going to do. Now I want to check the infant ID van. I want to make sure that this is in fact baby girl Smith, the one that I have been sent here to do my assessment on. And this is in fact her. So we will begin by performing our hand hygiene. And while we're doing this, it's a good idea just to take a look at her to get an overall assessment of how she's doing. When looking at her, we want to look at her position at rest. Does she have any increased work of breathing? Is she having any retractions? What's her color look like? She looks pink. She looks well perfused. The vitals on the vital sign look good. Is she having any spontaneous movement while sleeping? All of these things just kind of give a good general picture for you to start kind of building that differential diagnosis list. So, moving on, we have looked at our baby. We have begun to get kind of a feel of how she's doing at the present moment. She looks calm, she's sleeping, she's quiet. This is a great opportunity to begin our assessment. Now, all physical assessments follow the same type of template, I guess, if you will, which starts with observation, which is what we have done, and that's just simply taking a moment to look at the infant and take in as much data as you can just by looking and not doing anything. After observation, you can move on to auscultation. Auscultation is important to do while the infant's quiet because it can be difficult to discern between heart sounds and bowel sounds and breath sounds, and really pick up on those minute details such as murmurs or clicks or rubs or anything. It's hard to do when an infant's screaming. So you want to move on to auscultation second before she gets too riled up. And then moving on to palpation. Palpation is the most invasive, if you will. It gets a little bit more involved. They typically become more uncomfortable. Some areas can be more uncomfortable to palpate than others. So it's always best to save that for last. So, beginning, we will start by auscultating our breath sounds. And while we're doing that, we want to count the breath sounds for a full minute because infants, as you may know, or have very irregular breathing patterns. So, if you don't count for that full minute, you can get an accurate measurement. So, you want to just listen to the lung sounds, and you want to listen to them bilaterally on the same side. You want to listen right below the clavicle line, followed between the third and fourth intercostal space, and then the seventh and eighth intercostal space. And you want to do that left and right side. It's important to listen between the intercostal spaces and not on the ribs. After listening to the lung sounds and you've noted any adventitious breath sounds which should not be there, however, shortly after birth, infants can have some adventitious breath sounds, especially in this scenario where we have a preterm that was a C-section with no prior labor. So she probably has some retained fetal lung fluid that she needs some help clearing. So she might have adventitious breath sounds for a day or so. But otherwise, any longer than that, you shouldn't have that. You're going to note the pitch, the intensity, the duration of the breath sounds. Are they equal on both sides? You're going to listen with the bell and the diaphragm of the stethoscope. And after doing that, you can move on to the heart sounds. So the first thing you want to do when listening to the heart is do the rate first. And you want to start by trying to find the point of maximal impulse. And you find that by palpating the chest. It's found in the mitral area of the heart. So when you feel that, you should feel a vibrating. And that's the point of maximal impulse. And that's where you'll start your auscultating for the heart sounds. So you'll begin there. And there are 4 areas that you want to auscultate with the heart. Mitral, which is where you're starting with the point of maximal impulse, followed by, in no particular order, aortic, pulmonic, and tricuspid. Listen to all 4 of these areas. Notice any murmurs. Of course, a grade 1 or grade 2 murmur, systolic murmur during the first couple of days of life may be present as the neonate transitions from fetal circulation, and then those fetal structures begin to close. You might start to hear a murmur that will, as the turbulence increases in those close. But note any murmurs that you may hear, any clicks, any missed beats, any abnormalities, and you also want to note the rhythm, the strength, the regularity, and then after listening to the heart, you can move on to the bowels. And with the bowels, you want to listen to all 4 quadrants and note whether there were bowel sounds in all 4 quadrants. There should be. If you feel like they are hypotonic, you do need to listen for the full 5 to 10 minutes to ensure that they truly are hypotonic or absent. Sorry. So after listening to the abdomen, and I've noted the bowel sounds, I can go ahead and move on to one more thing, listening to the anterior and posterior fontanelle. This is done to assess for a bruit, which could be which is an indicator of an AV malformation. So you would just listen, anterior and posterior. So after we have auscultated all of our organs, we can grab a temperature. It's important to grab a temperature for the neonate, especially the premature neonate. Our baby is on a radiant warmer, so her temperature is being controlled by the warmer. So we don't necessarily have to worry too much with her becoming hypothermic by unswaddling her. However, since she is premature, that is always something that you have to be mindful of, that they may have some autoregulation and thermoregulation issues, so they could be stressed from the assessment causing hypothermia. So it's best just to get a baseline check before you get too far into your assessment. So we could check an axillary temperature real quick. And then after we get our axillary temperature, we could then move on to getting some measurements. Measurements are important because they allow us to plot the infant on the growth curves. Now this was already done for us, so we know that she was appropriate for gestational age, and we don't actually have any measurements from the prenatal records, but you would want to measure the head circumference in the occipital region. You would also want to measure the chest circumference, which is just at the widest part below the nipple line, or at the nipple line. And then you also would want to measure the length of the infant. Like I said, once you get those, obtain those, you can plot the infant and figure out if the infant is SGA, LGA, AGA. So after measurements, again, we're just looking at the infant. By this point, they might be waking up a little bit. So you just want to evaluate their tone, those spontaneous movements. You want to note whether or not the infant has any like jitteriness in their movements, or if they're smooth movements. Again, note any eye opening, any responsiveness to voice, any changes in vital signs, anything like that to show if the infant is stressed, if they're tolerating the assessment so far, and if you can continue. So now we will move into inspecting the skin, and you just want to get an overall assessment of the skin, noting the color. Is there any lanugo? Are there any rashes? Is there any lesions present? Any peeling for prostate? That's typical. You want to look at the scalp, especially if there was any instruments used during delivery, if there was any abrasions or incisions that were made from like an artificial rupture of membranes. So especially if an infant that has a lot of hair, you want to make sure to really take those hats off and get in the hair to assess the skin of the scalp. You also want to look at the mouth, the inside of the mouth, make sure the mucous membranes are moist and that they're pink and intact. If you can see the back of the mouth, you can assess the palate at that point to see if it's intact or not, if there's a cleft palate. You would want to look at the eyes, the skin around the eyes, look at the nails, make sure there are no abnormalities. Again, noting cap refill, you could do that now, or you could do that during cardiovascular assessment. Either way, you would also want to look for any discolorations, such as Mongolian spots, which are normal in some ethnicities. You also would want to see some of the common newborn rashes that you can alert parents for. We like the yellowish white vesicles, which is erythema toxicum, which is just normal newborn rash. You could let them know that that could literally move within minutes from different parts of the body, and it's usually gone within about a week. Another common finding in newborn skin is milia, like on the nose, the brow, the cheeks, and they're just little white yellow papules. Excuse me. And then after assessing the general skin, you can go ahead and move on to the head. So the head, you want to look at the size, you want to look at the shape, any molding. Since our infant is a C-section, you don't really anticipate any molding in this scenario. You want to palpate the sutures and the fontanelle. The fontanelle should be soft, not full or sunken or anything like that. The sutures should be well approximated, can be overriding in microcephaly, extreme prematurity, but they should feel kind of rigid on palpation. Normal anterior fontanelle size is typically about 0.5 centimeters to like 3.5, depending on the ethnicity. It could be larger in African American infants. And the posterior fontanelle is much smaller. It's usually about 0.5 centimeter. After feeling that, you can assess the hair. Is it evenly placed? Are there any strange patterns of hair? After hair, you would move on to any like swelling, particularly infants that are born via vacuum assisted or instrument assisted. We want to assess for any swelling or edema noted on the scalp. One of those would be caput. That's a pretty common one. Caput is swelling that typically it does cross suture lines. It's usually present immediately at birth, and it's gone within 2 to 3 days. Another form is a cephalohematoma. This one does not cross the suture lines. In fact, it has very demarcated border lines, which are the suture lines. And then the most severe form is subgaleal hemorrhage. This is when a large amount of blood, in fact, the entire baby's blood volume can be bled into this cavity. It can be presented with diffuse scalp edema that does cross sutures. There can be ecchymosis. There can be bruising, on the forehead, the eyes. It can be displacement of the ears. This truly is an emergency because this, like I said, the baby can completely bleed into that cavity for their entire blood volume. So making sure to look for any caput or any of those traumatic birth lesions here. We don't have any worries there. We would also want to take a look at any bruising on the face, particularly if it was a precipitous delivery or if it was an LGA baby. This one is not something we have to worry about again with a C-section and a smaller baby, but assess just for any trauma to the face from birth. Then we can move on to the general appearance of the face. You want to look at the characteristics. Are the eyes evenly spaced? Is the nose symmetric? Is the mouth symmetric? Is there anything abnormal with any features or anything? Just the general appearance. You then want to assess the eyes for symmetry. You can assess the epicanthal folds, the palpable fissures. These can be normal in some ethnicities. They can also be present in some trisomies, such as trisomy 21. You'd also want to evaluate eye movements, particularly the doll's eye reflex, and you would do that by turning your infant's head to one side, and their eyes should turn towards the opposite side, and you would want to check that bilaterally. So after checking that, you could utilize your ophthalmoscope to check your perla. I will just use this for my ophthalmoscope here. You'd want to check the pupils for equal and reactive light bilaterally, and that they're symmetric. You can also test the infant's tracking to this light. And you'd also want to check the red reflex, which is the Bruckner test. And this is done by holding the ophthalmoscope about 18 to 20 inches away from the infant's face, and their pupils should reflect a red light. Darker infants and African American infants may not, or their color may be more of like an opaque grayish white color instead of red, and that's normal. After assessing the eyes, you can move on to the ears. You'd want to check for normal placement, check for any type of pits or lesions, see if the canals are patent, any deformities, and make sure that the pinna is well formed in a term infant. We are 32 weeks. We may have a little bit more of a soft pinna, maybe a slower recoil, which is normal for gestation. You'd also want to assess the nose, make sure that it's symmetric and that the nares are patent and also symmetric, and that there's no occlusion. Any drainage should be noted. We have an NG tube in this infant. This is something that I would talk to mom and dad about and just let them know that this tube is here due to the fact that she did have CPAP. A lot of infants who do require CPAP after delivery benefit from having a feeding tube to help vent some of the air off that can accumulate in their belly. and it'd be a good idea to tell mom and dad that this also will benefit her, because when she starts eating, she already has the tube for feeding. So this tube will become her feeding tube when we do start doing formula or breast milk, whichever they choose, because she's a little bit young still to have to feed. But first of all, we have to figure out her respiratory issue, then we can move on to her nutrition. So again, you've assessed the nose. You want to move on to her mouth. Again, check for the size, the shape, the symmetry, movement. Is her jaw, does it look appropriate to the size of her face? Does it move normally? Check the tongue. Is there an appropriate, size frenulum to allow for normal tongue movements? You can see the top of the palate if it's intact, or if there's a cleft palate and a cleft lip. You then would want to check for any natal teeth. This can be present, although rare, and make sure that the mucous membranes are moist and pink and intact again. After assessing the mouth, you can start moving down to the trachea. You just want to assess the trachea for midline position. You want to assess the neck, make sure there are no masses. The lymph nodes should not be palpable. After palpating the neck, you also want to check for signs of torticollis, especially in a traumatic delivery or an LGA baby. Probably not so much of a concern for this baby, but still something that you just want to make sure of. After checking that, you can also check the nape of the neck for any excess skin. This is something that is seen in genetic disorders such as trisomy 21. After that, we would want to palpate both clavicles, make sure that they are both intact and symmetric. There's no crepitus felt, and then that there's no movement either. Then you would move on to the chest. You'd want to look at the overall shape of the chest. Excuse me. Also, you'd want to note the general movement of the chest with respirations. Are there any retractions such as supraclavicular, intercostal, subcostal, substernal? Any type of retraction should be noted, and then just the general overall work of breathing. The chest circumference should be done. It's, again, typically 2 to 3 centimeters smaller than the head. You would want to assess for nipples, the number, and that they are appropriately spaced. Wide nipples can be indicative of some genetic disorders. After that, you can move on to the the cardiac. You should have already felt for the point of maximal impulse when you were doing the auscultation, so we should already know where the point of maximal impulse is. It's important to know whether the precordium is active. Again, like I said, on smaller infants, this may be active, especially the first few days after birth. At this point, we could assess our pulses. We would first want to feel our femoral pulses first, since these pulses are more difficult to feel on an infant who is crying. So we will just remove the diaper here and feel our femoral pulses simultaneously, and just note their strength, the quality, and the regularity of them. Once you have palpated your femoral pulses, you can assess your brachial and radial pulses. It's a good idea. Side note, it's important to make sure you take off any equipment on the baby, such as blood pressures, pulse ox probes, especially when you're doing your skin assessment. And I should have mentioned that when I was doing my skin assessment. You never know what's lying underneath of a medical device or a blood pressure cuff. We could be bruising the arm here. There could be a burn at the pulse ox site that we don't know about. So it's important to always make sure to really thoroughly assess your skin and to remove any medical devices if they're not being used, like this blood pressure cuff, for example. Okay, back to the assessment. Again, you'd want to check your brachial and your radial pulses simultaneously bilaterally so that you could note any discrepancies. You'd want to note the strength. Excuse me again. Sorry, my mouth is dry. Well, my throat is dry. And note the strength. Yeah, I think I already said that. If you think that there is a concern for congenital heart disease, you can do a 4-extremity blood pressure. Higher blood pressures in the upper extremities and a weakened femoral pulse are indicative of coarctation of the aorta. So again, if there is concern for congenital heart disease, such as maternal history of diabetes or other clinical indications, you can always check that as a quick assessment tool. At this point, we would move on to assessing our abdominal area. We would want to check for any distension, any lumps or bumps or adhesions noted in the abdominal area. We would want to assess our umbilical cord. We should see three vessels, which would be 2 arteries and 1 vein. We would want to note the thickness, the size of the umbilical stump, the moisture. It's typically white, kind of gelatinous, the Wortman's jelly those first couple of days. So you just want to assess that and make sure that there's no occult umbilical or anything like that. So one way that you can get a better assessment of the abdominal area is to support the infant by putting the legs in the flex position, and at that point you can start with gentle palpation of the abdominal area. After that, you can go into a little bit deeper palpation for the abdominal muscles, and you can palpate the liver, which is 1 to 2 centimeters below the right costal margin, and you should note the firmness, the size, the overall shape of the liver. And then on the tip of the left costal margin, you should be able to palpate the spleen. And again, you'd want to notate the firmness, the size, and the overall shape. After palpating the spleen, you can palpate the kidneys. The kidneys are saved for last because these typically are a little bit more uncomfortable and infants can get disturbed with this. To do this, to check the kidneys, you'd want to put one hand under the infant's flank and then push up to palpate the kidneys, and you want to do this bilaterally. So at this point, the infant is probably pretty upset, which is okay because it doesn't really affect too much of the remaining assessment. You can always try to calm her by giving her the pacifier. I like to use this opportunity to have parents present to see if they want to talk to the infant, maybe hold the infant's hand or give the infant the pacifier. It just kind of gives them a little bit of empowerment and makes them feel like they are a part of the plan of care. So at this point, we would go back to our diaper area here, and we want to assess her genitals. For a female infant, you would want to assess the labia, clitoris, and the vaginal opening for asymmetry, any tags or lesions. Drainage may be there for neonatal menses from mom's hormones for those first week or so after delivery. This is normal. Typically in a term neonate, the labia majora is a little bit more puffy and edematous and is covering the labia minora. In a preterm neonate like ours at 32 weeks, I can't remember if she's 32 or 33, I keep getting mixed up. For a 32-weeker, we may see more of the labia minora prominent since the labia majora may not be covering the entire opening. At this point, we would evaluate anal patency. You can either obviously check for stool if she's past meconium, and that's a good indication that her anus is patent. Not a for sure sign because there could be a malformation causing stool to leak out of the urethra, but it's a pretty good indicator that her anus is patent. You can also use a cotton tip swab to check the patency of the anus too, but be careful not to insert too far into the rectum, as you can easily damage or tear or puncture. After that, we can put the infant's diaper on, and we will assess the infant's spine. And this is done by putting the infant on their abdomen, obviously in a comfortable position. And then we would want to note the curvature of the spine, the length of the spine, the symmetry of the spine. Make sure that it's intact. Note any tufts of hair, any dimples or skin disturbances. At this point, you can also assess the gluteal folds, make sure that they are symmetric. And then we can turn our infant over here. And now we will begin assessment on her extremities. So with her extremities, you really just want to look at the overall tone. Again, looking for the deformities. Do you see any polydactyly or syndactyly? Are there any contractures? Is the muscle tone good? Does she move on her own? Is she having trouble being organized for a 32-weeker? You might see some disorganization. But these are all things that you would want to assess when assessing the extremities. You can test the arm recoil, and to do that, you would put the infant's hands in the flexed position for 5 seconds. You would then extend them and then immediately lift up. The hands should return to midline if they are, in fact, term. If they're considered more term or overterm, the hands can come completely to the mouth. We wouldn't expect that with our infant, especially with her being hypotonic and premature. But again, this is a part of the gestational exam that's integrated into the physical exam. After testing that, you can look at your feet. You can look at the creases over the sole. You can also elicit the Babinski reflex by stroking your finger on the side of the foot, starting at the heel, moving towards the toes, and they should do the fan out. That is a positive reflex. You would want to check the hands for any palmar creases. You would obviously want to point out the IV to mom and dad. Since baby girl Smith is not eating, she's NPO, she is needing the IV fluids. So this IV is here for the time being to support her nutrition until she can begin eating. We would just explain to them that as she begins feeding, we would start weaning her IV fluid, and this would eventually come out, which is our goal. With the extremities, we'd also want to check range of motion, make sure that the strength is equal on both sides. So then for the hips, we can assess the Ortolani and Barlow maneuvers, and this just checks the stability of the hips, and there's actually 2 different procedures. So the first part of the procedure is the Ortolani, and this is adduction and posterior pressure to feel for dislocation. So it's actually kind of hard to do on the doll. It actually will not work that way, so I'll just talk about it. And then the Barlow maneuver is abduction and elevation to feel for reduction. And a clunk or a click or that popping feeling is just a positive finding for unstable hip joint. So after the Ortolani maneuver, you could just do your overall assessment now. Baby's probably crying and is irritated that you're messing with her, or she's being a good trooper and is participating. Either way, we are just about done here. So with our neuro assessment, obviously check her overall state. Is she active alert? Is she crying? Is she quiet alert? Is she transitional? What stage is she in? Is she making eye contact? Is she trying to engage with parents at this age? Probably not, but just something to note. We would want to check again the overall tone of the upper and lower extremities, and then note whether it's appropriate for gestational age. Again, we wouldn't expect her to have very vigorous tone since she is premature, and she has the underlying issue of exposure to magnesium sulfate. So she's expected to be pretty floppy. We would then want to test the head lag, and by doing that, we would just grab the infant's hands, and we could also elicit the grasp reflex by having them grab our hand. We would then slowly lift the head off the table, and head lag should be minimum in a full-term infant. We then would want to test trunk and the ventral suspension, and the way you would want to do that is the truncal innervation. You would want to apply pressure to one side of the spine, and if it's a positive finding, the infant's hip should flex towards the stimulation. Put her back down here. After that, we would want to try the root reflex, and the way to elicit the root reflex is to just gently stroke the side of the cheek, and her head should turn towards that side and her mouth should open. You could also elicit the suck reflex, so this is a great opportunity to assess the palate if you have not had a chance to do that. So you would just take a gloved finger. At this point, I would probably go ahead and change gloves since you've been in your diaper area. So perform good hand hygiene. Make sure parents see that and that they know that you are washing your hands and changing your gloves. Of course, I'm not going to get these gloves back on. So to save time, I'm just going to say that I put on new gloves here, okay? So then you would want to put a gloved finger inside the infant's mouth to elicit the suck reflex, and then you can also feel it on the gums and the palate. For 32 weeks, you may not get the suck reflex, may or may not, it just depends. Then you can try the fencing tonic neck reflex, and the way you would do that would be to turn the head towards one side. The infant should extend the upper extremity on the side that the head is turned towards. And then last but not least, you could try the step-in reflex. And to do that, you would hold the infant underneath of the axilla and then place their feet directly onto the edge of the bed or the exam table, and they should start to step with their feet and make walking movements. So, again, that concludes our assessment. It's important to make sure that mom and dad are there, or if they're there, that you're not ignoring them, that you're answering any questions that they have along the way, and that you're explaining any of your findings to them, explaining what's normal, explaining what's abnormal, and explaining what's expected for her gestational age and her maternal history. At this point, after doing our assessment, we should be able to look at any lab values that we have, look at our assessment data, go back and review the maternal history, and come up with the differential diagnosis here, which one could say could be related to apnea prematurity and exposure to maternal magnesium sulfate. So that concludes my demonstration of the physical assessment. I hope you enjoyed.